We're very happy to introduce our speaker today, Dr. Henry Honda, who actually needs no introduction, but just briefly, Dr. Honda has been at UCLA for quite some time, a good example of a UCLA lifer. I think you graduated from UCLA Medical School at 1987, as for your profile. But since then, he's been an integral part of UCLA. And for the medical students, residents, and fellows, he's a beloved member. And we're so thankful that he's able to give us a talk today. As you probably know, Dr. Honda is a master of the pun, and just talking to him about his experience with a high sensitivity troponin, I think last week or 2 weeks ago, you said to me, seems like everyone's very sensitive about high sensitivity troponins. So we'll let you get into your talk today and give us an update about how things are going with high sensitivity troponin at UCLA.
Thanks, Dr. Berg. So today's talk is the 24th day of the high sensitivity troponin here at UCLA. The talk will be broken down in 4 parts: background, evaluation of patients with suspected ACS, special cases. Then part 3 is evaluation of the post-op patients, and then we'll end with some other uses, maybe in preeclampsia and for Dr. Yang, cardiotoxicity. So April 5 was a special date for world and US events. St. Patrick returned to Ireland in 456 AD. Washington gave his first US presidential veto in 1792. And in 2023, the UCLA Health started using the high sensitivity troponin. The first patient was a little bit disappointing at first. It was an 18-year-old male, but I understand later that this was sort of more of a test patient. As background, the FDA approved this test in 2017, but it has been used in Europe, Canada, New Zealand, and Australia since 2010. And high sensitivity means that 50% of people on this Zoom call will have a detectable level. The results are reported in whole numbers, nanograms per liter, so that will be about 1,000 times compared to the old assay that's reported in nanograms per milliliter. The interpretation of this high sensitivity troponin will depend on both the absolute value as well as the change or delta between 2 values. There is a sex-specific cutoff for the 99th percentile, higher in men of 20 compared to women at 12. And in addition to the sex-specific cutoff, a delta of more than 5 may be abnormal and due to myocardial injury or infarction. So definition of myocardial injury or infarction, just as a reminder, myocardial injury means that you just have one troponin level over the 99th percentile. Myocardial infarction is a subset of myocardial injury, but it is due to ischemia. There is a rise and fall in troponin levels, and at least one of the following: ischemic symptoms, which may not be present, let's say in the post-op case, new ischemic changes on EKG or new Q waves, new evidence for regional wall motion abnormalities or perfusion abnormalities, or evidence for clot. So why the change? In the emergency department, the use of high sensitivity troponin can more accurately identify patients without ACS and may allow for earlier discharges from the ER. So a 3-hour decrease in length of stay is thought to lead to a $2 billion savings in healthcare costs in the US. The high sensitivity troponin also has a higher negative predictive value for ACS, but also has a lower specificity. High sensitivity troponin will also more accurately identify patients with injury And the companies, for some reason, will no longer make the assays, so everyone will need to buy the platforms. And at least in Europe, there's evidence for cost savings, and we'll talk about the US a little later. So what is the high sensitivity troponins, what the impact on the number of diagnoses of injury and infarction in the Mayo Clinic? They propose for patients with the diagnosis of being evaluated for chest pain that the number of acute MIs will be going from 3.3 to 8.1%, with a more increase in the type 2 MIs. But the category that will really increase will be patients with myocardial injury from 11.3% to 38.4%. So just a word on levels. Again, the 99th percentile is 12 for women and 20 for men. Very high levels can be seen in the up to, let's say, 50,000 or even higher. And we will need to remind our house staff to, for patients post-procedure, since they may have very high troponins, to obtain the high sensitivity with troponin with dilution. Because numbers over 27,000, they have to change the cartridges, and that takes about 2 hours in time. So hopefully we could minimize too many levels without dilution. So just as a reminder, please remind your house staff to order the high sensitivity troponin with dilution for your post-PCI patients. One way to look at the levels for high sensitivity troponin is to break them down into low, intermediate, high, or very high levels. So low is less than 5. High is over the 99th percentile. That gets you into myocardial injury already. Very high is over 50. Delta of less than 5 is low, and over 20 is high. And in the ER, as part of the algorithm, there is the heart score to get an increase in negative predictor value. The heart score, as you know, H is for history. You get points for EKG, age, risk factors, and high sensitivity to troponin. So heart score of 0 to 3 is thought to be low. So for when using the ER algorithm, so these patients are probably for, many of them we will not see, involves 3 elements: the symptoms, signs, and the EKG, plus the troponin level and the risk assessment score. And then high levels of either the troponin I or deltas will be an inpatient admission, and very low levels go straight home from the ER. Okay, so this is the algorithm that the ER residents, as well as the internal medicine residents, can use. As a reminder, most of this algorithm is based with non-ischemic EKG changes. So patients presenting with acute possible ACS, if they have an abnormal EKG, that does not go down this algorithm. But for a non-ischemic EKG, if you have a less than 5, and are low risk, you may be considered for discharge. In Europe, they don't use the heart score, or they just use the troponin and send them home. Over 50, you end up in the admission, and anything between, let's say, intermediate or, let's say, high risk, you get a second troponin at 2 hours, and then by this algorithm, you undergo triage. For those patients who are admitted to the observation unit, then we suggest obtaining a third high sensitive troponin 2 hours after the second. And again, the patients are triaged based on the the third troponin level. So how do these algorithms work? So the ER always focuses on, let's say, 30-day outcomes. It turns out the delta increases the sensitivity for the identifying patients with MI about 10% in those patients with an indeterminate troponin level. I mean, partly this is because we're making decisions at 1 or 2 hours. And so that might not give enough time for the troponin absolute values be elevated, but delta will make the diagnosis for you. And the addition of the heart score increases, let's say, the negative predictive value from 98.4 to greater than 99.3%. So that's where the heart score is useful. However, that means that more patients are admitted for observation. So what are the hard outcomes in the US for this test? So here in the high sensitivity of troponin, in the evaluation of patients with ACS, 48,282 patients with possible ACS. All of these patients had both the conventional and high sensitivity troponins drawn. Only one of the results were available to physicians. It turns out that 1,700 patients had a positive high sensitivity troponin, but their conventional levels were not elevated. And so this is a great group to compare. Okay, 83% of this group were women. They were older. And of these patients, 1,051 were treated because they were that high sensitivity troponin value was revealed, and 720 were not. The results of the high sensitivity troponin was not known to the physician. The incidence of myocardial infarction or death was similar in both groups. So I guess the high sensitivity troponin at least doesn't lead to higher mortality. How about in Boston? They looked at, the concern is when you have all these patients being admitted with high sensitivity troponins, or at least being labeled with injury, are you going to get so many tests, and are you going to bankrupt the system? And so more studies were done in Boston. They were looking at patients with, let's say, before the high sensitivity troponin and after. Turns out that there were more EKGs done, and troponins beget troponins. There were more troponin tests ordered and more EKGs ordered, but it ends up that actually the big ticket items, echocardiograms or stress tests or coronary CTAs, actually there was a decrease in the number of these tests that are ordered. And then also looking at, let's say, the length of stay, this was the disturbing portion. There was actually a slight increase in the length of stay and a $16 per patient increase for those patients with chest pain. So not the $2 billion windfall that was expected, at least not yet. Okay, so one third study looking at outcomes. This is from the National Cardiovascular Data Registry, the former Get With the Guideline registry. About 2019, about 3.3% of hospitals were using the high sensitivity troponin. We're up to, in 2021, up to a third. And looking at, let's say, in those patients with non-STEMIs or patients with low-risk chest pain, the number of stress tests in these groups, let's say with the high sensitivity troponin and with the conventional, pretty much the same. Actually, There was an increase in use of echoes when the high sensitivity troponins came on board in those patients with non-STEMIs. There was actually a decrease in the use of angiograms in patients with low risk chest pain. So they believed the results of the troponin and did not cap the patients. And the length of stay was about an hour less for non-STEMIs, and even 0.4 hours for the low-risk chest pain. There are a couple of special cases. The elderly. As you could see, there'd be a higher percent of patients who are elderly who will have an elevated troponin over the 99th percentile. But it turns out that most of those are not type 1 or type 2 MIs, but are due to myocardial injury. And the same finding is with patients with renal failure. You could see here, patients with a GFR less than 30, you see that almost 3/4 of those patients have a greater than 99th percentile of troponin, but most of that is due to not in type 1 or type 2 MIs. How sensitive are these tests? Let's try mental stress ischemia prognosis study. And in this study, there were 587 patients with stable coronary artery disease. And their stress was public speaking tasks, like giving grand rounds over Zoom, I suppose, or treadmill tests. And ischemia was seen in about 16% of people with public speaking, and actually 35% of patients with a treadmill. And you could see that about a third of patients have increase in troponin with treadmill. There's also an increase in troponin with mental stress. Turns out that those patients already had a baseline increase in troponin. How about outcomes? Okay, I don't know if, oh, Jeff Shu is on the line. Okay, so Nijmegen is a 4-day march in Netherlands. And I think in July, if you want to sign up, if they still have slots for you, Jeff. 725 participants, age 54 to 69, walk about 30 to 55 kilometers in 8 hours. It turns out that 1% of these patients already had the baseline troponin over 99th percentile, and about 10% end up after the walk. You could see that if you have coronary artery disease, your levels can go up to 15 with 15, and you have an increased mortality rate. Even at 1 year, going out to 8 years. So with this this test, we are going to be defining more patients with myocardial injury and type 2 MIs. And it's already known that mortality rates for patients with myocardial injury or type 2 MIs are greater than patients with type 1 MIs, partly due to the success of revascularization and guideline-directed medical therapy. And so the mortality rates are for the patients that we define with myocardial injury or type 2 MI are higher. So there was an interesting editorial adding insult to injury. Are there any treatments for myocardial injury and type 2 MIs? And so in this patient with, in this group, in the study, in the Sweetheart cohort, in those patients with, let's say, with MI with non-obstructive coronary disease, and many of them, 80%, were type 2 MIs. Statins actually improved the mortality or decreases or increased survival by about 23%. ARBs maybe by 18%. Beta blockers were almost significant, and DAPT was a wash. So some caveats with this high sensitivity troponin assay. If the patients come into the ER less than 3 hours of onset of symptoms, that it might not give enough time for the troponin to rise. And so they will need a 3-hour and not 2-hour troponin after the first one that was drawn. And also, if the troponins are too late, then the troponins are too late, let's say, well, if the patient had symptoms over 12 hours, then the peak may be very slow and might be confused with chronic myocardial injury. The other caveat is that we won't be able to compare easily troponin values from assay to assay. So here is the Beckman-Coulter assay here at UCLA, but there are many other companies with troponin eyes, Abbott and Roche. Roche is a troponin T. Siemens is another troponin I, and there are various cutoffs. So this ends the first section for high sensitivity troponin at UCLA. Okay, let's go to the post-op patients. So this is the universe of all surgeries. Myocardial injury, greater than the 99th percentile in about 20 to 25%. Here, myocardial injury and non-cardiac surgery. This is a group of patients that's about 18% and excludes injury due to non-ischemic causes like PE, sepsis, and about 1 to 2% of patients over 75 will have an infarction. So this study, in 2017 was a vision study, and first taught us that small increases in post-op troponin, even small increases was associated with 30-day mortality. So in this large study of 21,842 patients over 45 years old, various types of surgery, only 35% was low risk, that even a slight increase over the 99th percentile, so this in the Roche system was 14, that even the small increase was associated with mortality. Now, and that's at 30 days. How about longer term? So the Basel PMI cohort included 7,754 patients. They included anyone over 65, anyone with coronary artery disease, peripheral vascular disease, or stroke over 45, and in surgeries requiring an overnight stay. The high sensitivity troponin T in this group was measured pre-op, as well as post-op day 1 and post-op day 2. And injury or infarction, perioperative myocardial injury was defined as an increase of more than 14. Now, in the supplemental methods section, and maybe the fellows will like this, they wrote down that no cardiology consultations due to PMI would be ever performed during the weekends, on public holidays, whenever the cardiologist on call was busy with other more urgent patients, or in the case if the patients were treated in the ICU. So, but I'm not sure if that's going to be accepted with the internal medicine administration. What were the one-year outcomes? So it turns out that about 13% of patients had a perioperative myocardial injury. Most of those were, let's say, non-cardiac. The cardiac patients, about 7% had type 1 MIs, 5% had tachyarrhythmias. This is not sinus tach, it'd be probably mostly AFib, and 4% had acute heart failure. The vast majority was likely type 2 myocardial infarction, parentheses, probably myocardial ischemia, or extracardiac, sepsis, PE, stroke, or trauma. Well, how did these patients do? Well, maybe half of them died from all-cause mortality. let's say 40% if they presented with tachyarrhythmia, and 50% if they presented with acute heart failure. And the MACE, you could see, is all of them was over 20%, but almost close to 56% for acute heart failure. So this group of patients with PMI are at high risk, but just like the editorial for type 2 MIs and injury, are we just adding insult to injury? So, so here is our algorithm for the peri-op patients. Again, you have low, intermediate, high, and very high risk. Then asking our surgical colleagues to obtain consultations in certain patients, and maybe dividing them up with internal medicine for other patients. And as Dr. Parikh likes to emphasize, clinical judgment always supersedes any algorithm. So what about therapy for these post-operative myocardial injury? Okay, well, here's something. The treatment of acute attack must be directed primarily to the correction of hemodynamic alterations induced by surgery. General measures include relief of pain and sedation, relief of anoxia with oxygen and adequate ventilation. And this, the next one will date it. Treatment of shock with morphine, oxygen, vasopressor agents, and rapid digitalization. Treatment of pulmonary edema and heart failure with oxygen, more digitalization and diuretics. Treatment of thromboembolism with anticoagulants, bed and chair rest to reduce the work of the heart, and general measures. So this was done by Simon Dack, I think was first editorial for the JACC, and this was in 1963. So I am sure things have improved since then. So let's look at what are our therapies for post-op MIs. Okay, in the managed trial, this was 1,754 patients. They ran out of funding and they had a slow enrollment. Nevertheless, this group was vision-like patients, 45 years old, non-cardiac surgery, and they had to be enrolled within 35 days of their abnormal troponin. And these post-op patients were randomized to receive Pradaxa, 100 milligrams twice a day, or placebo. And here are the results at 16 months of follow-up. With a very, very large composite endpoint of vascular death, MI, stroke, peripheral artery thrombosis, amputation, and VTE, there was a significant decrease in this endpoint in patients who received Pradaxa versus no placebo. And all the other endpoints were crossed 1. Not only did they run out of money, 40% of patients discontinued the drug. So this is going to be a difficult study to implement. You know, are there any groups of patients in this study that look like they would really benefit from DAPT? I mean, sorry, not that, would benefit from Pradaxa after surgery, maybe peripheral vascular disease, you know, and certainly not after 5 days after the event. Okay, how about statins? Okay, so here we have patients, 5,100 patients with myocardial injury due to non-ischemic non-cardiac surgery. It looks like actually statins decreased the death rate for patients, non-cardiac deaths, and versus, let's say, patients who had a cardiac death, there was a less decrease. And how about, you know, you were having therapy after discharge with antiplatelets, beta blockers, ACE, or statins? the number 1, 2, or 3 drugs or more, it seemed that if you increased the number of these drugs at time of discharge, that there was a decreased decreased mortality in patients who were treated with more, let's say, guideline-directed medical therapy, let's say for ischemic heart disease, it turns out. So this is going to be a very fruitful area of research because it's very unclear what's the best therapy for post-op MI. Obviously, with plaque rupture and STEMI, acute revascularization, actually, if the patients can tolerate anticoagulation, is a good results. But here with type 2, with supply and demand mismatch, obviously you work on the supply and demand, but other than that, optimal management is uncertain. Okay, so we're going to end with 2 other uses of high sensitivity troponin, because there might be some very useful things for high sensitivity troponin. So one of the abstracts at ACC looked at patients who are at high risk for preeclampsia, and a 14-week troponin, so this was even before preeclampsia developed, that it seemed like the 14-week troponin seemed to maybe predict severe preeclampsia. And since Dr. Yang is on the line, we have the high sensitivity troponin can predict anthracycline cardiotoxicity. As you could see, here are patients who received anthracycline, and there's a group of patients in tertiles that have different levels. Does this matter? So it looks like in this study, the 3-month troponin would predict long-term, would predict survival. Okay, so summary on high sensitivity troponin. 1, high sensitivity troponin will increase the diagnosis of MI, especially type 2 MI and myocardial ischemia. High sensitivity troponin will allow immediate rule out or rule in about 1/3 of patients. High sensitivity troponin will identify post-operative patients at high risk for MACE and mortality. And additional uses for this test may predict cardiac risk in patients without ACS. So I want to thank the many people involved in the high sensitivity troponin rollout, including Dr. Vonero, Busatil, Song, and Waxman. And I want to thank you for your attention. Is Dr. Berg going to appear?
Thank you, Dr. Honda. That was an excellent overview, of course. I want to open up if there's any questions for the group.
Henry, thank you for being our troponin ambassador. I was going to say, I was hoping the Chief Fellows would introduce you as saying, you know, Dr. Honda's passion didn't find high sensitive troponin found Dr. Honda. But a couple of things I would say, since the rollout in April, again, I've only done 1 week of consults. I think the interesting one silver lining is that house staff are looking at ECGs a lot more closely. It's almost as if they're trying to justify the consult because they're worried that they're missing some subclinical findings. And I've noticed that people fixate more on ECGs and other markers of ischemia. So I'm trying to be positive about it. I would say that's one thing that I think has been one good thing, that people are actually taking the time to look at, you know, ECGs closely to kind of say, well, the tropes are high, so is there some subtle stuff that we're missing on rhythm monitor? So maybe from an educational standpoint, there may be that benefit. At least a commentary in cardio-oncology, actually, I had a discussion with leadership. You know, really, you know, again, I'm not looking for immune check. You know, the one thing that we're wondering about is whether high sensitivity troponin should be checked, you know, before starting immune checkpoint inhibitor therapy. And I'm not doing this, frankly, to look for cardiotoxicity. The goal really is to kind of avoid unnecessary alarms and consternations, because as you know, a lot of these cancer patients have pre-existing cardiovascular disease or may have prior subclinical cardiotoxicity. And a de novo high sensitivity troponin, in the middle of a hospital admission for some kind of adverse problem will probably may generate a lot of alarm bells on, oh, this is myocarditis or not. And a baseline check, even if elevated, hopefully will stave off a lot of these alarms and not interrupt treatment. So, so we're going to probably bring that up to the oncology division as a whole to say, probably it's good to get a baseline, and unless it's very abnormally high and or concern for cardiac issues, to refer. But, it's probably good to get one at baseline, which some people like Tom Nealon and MGH are advocating for in general as a baseline.
Henry, Mike Fishbein. I'm not a cardiologist, but there are patients who have severe coronary disease who can have a normal EKG and a normal troponin, if they're having unstable angina, and they're discharged. Those are the patients I see. Is there any concern that, the people are going to have be overconfident and over-reliant because they have a negative high sensitivity troponin? And what's the role of stress testing, low-level stress testing in relation to now the new troponin tests?
So, great questions. It appears that for those patients who are sent home from the ER, that we'll miss about 1 in 200 of patients, and those patients may be difficult to pick up no matter what. The assay is more sensitive, and but still we'll miss those patients. Unclear whether hopefully they will, if they have any symptoms, that even though they're sent home, they have, hopefully, if they have symptoms, hopefully they have adequate follow-up. But unfortunately, they're going to be missing about 1 in 200. Stress testing, inpatient stress testing, outpatient stress testing. There's so many patients with, you triple the number of myocardial ischemia, patients with myocardial ischemia with the new troponin. And yet the Mayo Clinic and the Boston study and the National Cardiovascular Registry, unbelievably, there wasn't an increase in the number of tests. So that's actually surprising to me. But I guess it's that's to be the algorithm is purposely silent on which patients should have further testing.
Yeah, I mean, I think, again, I like a biomarker is just one tool, right, in a multi-variable and, more importantly, clinical assessment. I mean, I think, a biomarker, whether positive or negative, in the end, nothing still beats a good history and evaluation of other markers of ischemia. I mean, 2 weeks ago, we had a patient with known CAD with a kind of concerning story whose high sensitivity troponins were actually in the 20s. And what made us cath her was that she had dynamic unstable angina like ECG changes. So clinical, right, exactly. I mean, in the end, it's all about clinical judgment to help decide what the troponin is due to, or if it's even negative. And she had a high-grade circ lesion, so it was. So I think, again, we know that a lot of this, unfortunately, will fall sometimes into protocol, but the goal really is to not rely on it. It's just more of a decision-making tool, but not drive the decision-making. It's opposed to everything else that we put into it. So, so it's just interesting that we've seen cases where we're starting to see cases now that even then, like the history and looking at other markers like a very concerning ECG or other things can still lead to, treating the patient like ACS. So.
Yeah. Henry, this is Frady. I have to say that was like the best talk I've heard on troponin. It was really superb, very good.
I'll have to pay you
covered
do I pay you $100 before or after the meeting?
I'll let you know. It was great. But just a couple points. Firstly, to Mike's point, Mike Fishbine's point, I think that it should be just drummed into clinical individuals that unstable angina is a clinical diagnosis. It's not a diagnosis of EKG. It's not a diagnosis of biomarkers. It's just a clinical story. And because the treatment is so different, which includes anticoagulation, and the outcome is so different, they just have to know that you can't rely on it because the troponins are supposed to be. That's the definition of unstable angina. It's ACS with negative troponins. I think it just has to be sort of drummed in. Just a couple comments to you, Henry. I think it's great that you came up with all those different assays that have these troponin eyes, because fellows and house staff, rotate through different places at the VA. I'm not sure which one we have, it's Siemens or Abbott or what it is, but it's double. The cutoff level is maybe not even double, I think triple, because we have 42 and 50 or something like that is normal troponin. So it's very important that trainees know that as they rotate through different locations, that the assay might be very different. And as such, even the delta is different, right? Because yours is 5, because you started with 10 and 12 and things like that. Ours are 45 and 50, so the delta is more like 12. And the last comment I wanted to make was that, all of this is how well you use it. As you said, there'll be a huge rise in what we define as myocardial injury because these are so sensitive. I think the key thing is to know how to distinguish myocardial injury from acute MI, that rise and fall, that unfortunately, WHO make these universal definitions. They don't exactly say what the rise and fall is, but it's typically, as you say, 20% within that, and 50% when we look at the old troponin and CKMB curves and all, we're talking about the level of drop that occurs within 24 hours. So I think distinguishing acute MI from myocardial injury is going to be key. And the last point is that I think that because we're able to make these observations of myocardial injury so much better now, we'll be able to risk stratify better. And a lot of these people will end up having, CAD. So we'll be picking up more people, and I'm sure that'll raise the cost, but it'll probably improve the outcome. But if we don't distinguish myocardial injury from acute MI, we're also going to be having a heck of a lot more admissions and consultation, which also adds to the cost that, doesn't factor in all those people that we discharge with the $2 billion savings from it.
Thank you.
Great talk.
Thank you. So the chat bot, I guess I could turn off, Dr. Berg.
Well, there's no other questions. Well, thank you for your time, Dr. Honda, and thank you for everyone for joining us today.
Thank you. See you.
Thank you.